Sure. So this is the, thank you, Sheila. This is the policies group. Our task was to try to answer the question that's at the top of the slide here, how to create an environment that's conducive to improving quality of care. We approached the problem in a ranging conversation, but arrived, I think, at a hopefully useful set of suggestions here. The first is we started with this, if I can, a process map for policy formulation to translation and implementation. We started with the idea of how policies are made, how they're translated into action, how they then get implemented, and how there might be a feedback loop to the original formulation of policy. So in the first area, we suggested that we might want to investigate a little bit more and in greater detail the concept of co-production of policies with community stakeholders, not just patients, but also providers and others that might be interested in the object of that particular policy. The second area was around translation, and here, getting to your point, I think, Pierre, around motivation, there was a sense that policy needs to have or be oriented towards some sort of ambition that would be galvanizing to the healthcare delivery system and potentially to the wider public. There was a specific strategy for how to help with the translation of quality improvement concepts and ideas into policymakers' knowledge base, and that's to include them as participants in all of our efforts. So if we're running a collaborative, we're running SBMR, we're running one of the 6 strategies, find a way to connect to the policymakers that are govern or sit in whatever offices that might be useful participants in that process. The third sort of area around policy translation was the notion of creating what was described as day-to-day capability for improvement at scale. There have been articulations of this. There's in the NHS in the UK right now, they're creating 5,000 patient safety officers. Don at CMS was working on creating an army of improvement capability within the United States. There's a notion that we were discussing about, in fact, if we were going to try to create a improvement at scale, that we needed to create the capability to do that. And then the last one has come up multiple times during the course of the conversation that we've had around the room over the last 2 days, is this concept of creating useful routine data systems that policymakers can use to understand the impact of their efforts. Point number 3 was around feedback. So we started describing the design of policy and its effects. Towards the middle of the discussion, we started to describe the effects of implementation and how it might be used to inform policy. We started to describe what I would describe as a learning system, and creating the parameters of what a learning system might look like, so that the impacts of a particular policy as they get implemented are understood by the policymakers, and then that's sort of that allows a reformulation of the original policy. To support all of this, we briefly touched on this concept, and I think it needs a lot more exploration of what organizational models, what systems might be in place in a country that might allow us to support these key steps in policy translation. That might be composed not just of the health sector, but also of the health workforce, as well as healthcare financing. So the organizational models that support the articulation of policy and its translation probably deserves further exploration. And then just a comment that I think will lead into Margaret's presentation. There seems to be a number of opportunities. We pointed out several during our conversation across all 4 of the original steps here that are significant research opportunities, because a lot of what's in this is either vaguely present in the evidence base or certainly needs further detailed exploration.
Thank you, Kedar. Comments or questions? Amplification from the group, Edgar.
One comment. I particularly like the number 1 when they say that policies have to be co-produced with communities. Perhaps not necessarily is always co-produced. Sometimes there is a pull factor because it seems that we understand that policymakers make decisions based on rational things, and that's not the case always. Many times they make decisions, several people here have been policymakers, based on pressures, on real pressures. And if we don't create the centers of pressures, policies won't come. And this is a very important point. So I like perhaps to expand a little point 1 because I think it's very, very important.
And I would just add one additional comment, Edgar, to that, which is that while we discuss this, we also discussed how incredibly difficult this is to do, and that we need many more examples, whether in case study or other formats, of this being done and done well. So thank you for that point.
Nachket.
One issue that came up in our group, which I thought may have a bearing on this, one of our colleagues in the group made it, was that sometimes this issue of policy to improve quality may be framed too narrowly as a quality policy, whereas in fact how you finance the system, how you staff the system, many aspects actually have a bearing directly on quality, and so that's something that needs to be borne in mind. That it's more a health systems design, all the components will have an impact on what you finally see.
I think we agree completely with that suggestion. That's exactly right.
Gary?
Query, was there any suggestion about the role of professional organizations, society, as vehicles to influence the culture and the practice patterns?
We did discuss a variety of stakeholders in the context of our discussion: government, of course, frontline sort of care providers, and the professions, kind of more generally speaking. And so there was a discussion about this not just being about the role of government and alone, but also how government and other stakeholders collaborate to formulate effective strategies for improving quality in the sector. So absolutely, there was a discussion about that.
I think number 3 is particularly interesting with regards to learning. I think there ought to be another arrow that talked about adaptiveness, willing to actually not only learn, but also modify and adapt the policy issues.
Thank you for that comment. The intention, if we had a time to create a nicer illustration of this, was that in fact exactly what you're describing. The intention of this was to create a recursive line that would lead from the implementation back to the sort of concept of policy formulation and allow that adaptive process to take place and allow a revision to the notional policy that might have been put in place in the beginning.